Yeah, I think I want them to walk away with the microbiome is the most important, clearly biased, and the most
You're not biased at all. It's okay.
is the most important, the most magical part of a growing baby. And most importantly, it's the part that we can actually influence and make a difference on early in life. And so being aware of that, because it controls so many things like we spoke about, being aware of that, respecting the microbiome, both with respect to antibiotics, hygiene, but also nutrition, really is the key not just to a healthy childhood, but is then the key to a healthy adulthood and beyond.
Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals, like you, better understand, support, and nurture the entire NICU family. Howdy, everybody, and welcome back to another episode of NICU Heroes. I'm going to say full disclosure that I interview a lot of great people this particular year. However, today's topic means a lot to me, and there's a reason why. Is because our preemie spent 44 days in the NICU, and we really thought he was going to blow in and out until on day 9, he got an illness called necrotizing enterocolitis. We will touch a little bit on neck in this particular episode, but we're really talking about the preemie microbiome in totality. So there's a lot. So the reason that I wanted to come clean with you is that this one means a lot to me because I learned the importance of having a healthy gut, not only when they're a neonate, but what does that look like when they become a toddler, when they become a preteen, and our preemie is now a full-fledged teenager, is a 16-year-old. And so it is a part of the body that we got to know well. And I was really fascinated to visit with today's guest. So if you've ever wondered, like, what is a healthy gut? What are some things that we can affect outcomes if we intervene earlier? What are some things that we miss that we should be looking for? This is the episode for you. I'm really grateful that my guest today is Dr. Rina Sanghavi. She's a professor of pediatrics at UT Southwestern Medical Center, Children's Health, and Children's Medical Center in Dallas, where she's the director of pediatric neurogastroenterology. She helped establish the Aerodigestive Clinic, the Chronic Abdominal Pain Program, Motility, and Biofeedback Program, as well as the Colorectal Center at her institution. She knows a lot, y'all. She also holds several administrative and leadership positions, including president of the medical dental staff, chair of the UTSW, so that's UT Southwestern, Faculty Compensation Committee, chair of the Pediatric Business Strategy Group, and she's also the chair of the Women in Medicine Committee for, and I'm going to spell this out for you, NASPGHAN. Through her work here at UT Southwestern, she's pioneered a national junior faculty conference for professional development of pediatric gastroenterologists, mentorship, as well as recognition programs for women. She was awarded, and I love the name of this award, the Scrubs and Heels Breaking the Glass Ceiling Award for her work on advancing women in GI. She's an advocate for women leaders in medicine, equity, and empathetic leadership, and she's also passionate about marrying the business aspect of a medical practice with efficiency and promoting wellness within clinicians, especially in an academic environment. She's published extensively on gender equity in medicine, and she's been invited for lectures and talks on gender equity and leadership nationally and internationally. In addition, she's also been recognized with lots of awards, including the Clinical Excellence Award at UT Southwestern. She is an expert in her field. If you have never heard of neurogastroenterology, don't worry, we talk about that. But let's get to a really great episode of NICU Heroes this particular month.
I'm really grateful to have you here, Dr. Sanghavi. I have a lot of questions for you, but I think the most important one is I like for people to know your why. So I always ask, particularly if I have a doctor or clinician on, I always say, like, what's your why? Why did you get into medicine? You could have chosen a lot of things, but why medicine? And in your case, why pediatrics?
Yeah, I've always loved children, and I think the beauty of pediatrics is you get to make a difference so early on in the lives of these babies. And to me, my fulfillment, my value comes when they're 18 or 20 and they come back and say, Dr. Sanghavi, I've took out my G tube or I'm going to college. I love that. And I think to me that it just is a way of serving humankind that I have really found is the closest I felt to this higher power that people call God. So
Yeah.
that was my calling into medicine. And then, again, pediatrics. And I really think I'm so passionate about it, even more so now, because I'm a mother. I have two children of my own. And I did have a third who I lost very early on. And so to me, it is just when you look at your children when they're born, they're the most precious thing you've ever held. And I feel that for every parent who holds their child. And so a lot for me is about how do we help navigate the journey, not as a physician and a patient, but more as partners together in this journey called parenthood. And I love the partnership I have with my families.
I find that most physicians who are also parents, they said that that shifted their maybe not necessarily what they do, but how they approach it. And I think that you articulated that really well. So you have a specialty in, I want to make sure that I say this right, neurogastroenterology. Did I say that correct? Okay.
You did it. Yeah.
Okay. So tell us first of all what that is and then what that really means.
So neurogastroenterology is a fancy word that talks about dealing with the movement of the intestine and specifically the nerves and muscles that control movement of the intestine. It also involves the signaling that's constantly going on between the gut and the brain. It's called the gut-brain axis. And so neurogastroenterologists are specialists who are trained in monitoring the speed of the intestine, and we can put tubes in different portions of the intestine to look for that. We also specialize in what's now called disorders of gut brain interaction. And these examples of these are things like functional abdominal pain, irritable bowel syndrome, reflux, etc. And then I think a big part of what we do as well is trying to help improve the quality of life for a lot of these conditions where there's not necessarily a cure, but it's more about managing the condition. We do a lot of funky studies, and I think a lot of it is physics based. And so if you like physics, you'll like this specialty.
I love that. Okay. So let's talk about a gut of a preemie or a preterm infant versus a full term. What would be some of the biggest differences between the maturation of the gut between those two populations of babies?
So, one big difference is in the movement or motility of the gut. Some studies have been done that show that really coordinated movement or motility of the gut is established close to 34 to 35 weeks of gestation. And that's really, especially when the infant in the mother's womb is able to swallow the amniotic fluid in a coordinated manner. So that's one of the biggest difference if you're born before that 34, 35-week gestational age. The other big difference is in the microbiome. So there are excellent studies that have been done that show that, the baby has to go through the mother's birth canal to start establishing the microbiome or the good bacteria within their intestine. Babies who are born premature usually have a much different microbiome than the babies who are born at term. And to add to that, most babies who are born premature have two additional insults, so to say, to their microbiome. For one, they're typically born via emergency C-section, and we know that that causes more dysbiosis than being born through a natural vaginal delivery. And then the second thing is a lot of these preemie babies end up needing multiple courses of antibiotics because they are at higher risk for infection. And so early on in life, in that critical period when your microbiome is being established, giving antibiotics causes dysbiosis. Now, the microbiome is important not just because it's, hey, good, fun bacteria, but the microbiome plays a really important role in establishing normal motility in human babies. It also plays a really important role in establishing the immune system of human babies. And then it plays a really important role in the gut brain signaling, teaching the baby early on what is safe and what is fun. For example, eating food should be safe versus this kind of stimulus is pain, or this kind of stimulus is danger and you need to be aware of it. And the microbiome plays a role in that. So very early on, if you have dysbiosis, those signals get crossed and messed up as they're getting established, and that then leads to long-term consequences with DGBIs, disorders of blood gut brain interaction.
So what I'm hearing you say is the gut's really important. It dictates a lot. I mean, I don't think that I truly understood that until we had our own preemie. And then I realized, oh my gosh, it all starts with the movement of the gut and how things are moving. That tells us how they're doing post-op, or there are a lot of things that I think you can find out from that. I'm glad that you brought up antibiotics because I did want to ask you about that. So obviously, antibiotics, a lot of babies in the neonatal intensive care unit have to have antibiotics. But then we also know, like you said, that that interrupts the microbiome. So Dr. Sangvi, how do you balance the need to address whatever the issue is, but also protecting this really like easily fluctuating gut microbiome and making sure that it's developing healthily?
Yes, I'm going to back up a little bit, Kathryn, and I'm going to say first, why is it important in the first 2 years of life? Because the infant microbiome is going through rapid and fairly dramatic changes in the first 2 years of life. And it's these changes that are important and that eventually help the baby towards establishing a normal adult kind of microbiome. And so we find that especially the first two, but really the first 5, 10 years of life, any insult to the microbiome is sort of magnified many more fold than it would be if that same insult happened in an adult. One of the bigger factors that does influence the microbiome is the kind of nutrition the baby is receiving. And so I take advantage of the fact. So a lot of premature babies will need antibiotics. And to be honest, in most cases, those are life-saving antibiotics. So
Right.
if I had to pick between being alive and dysbiosis, I think we all know
Yeah.
that choice is being alive. On the other hand, how do you prevent dysbiosis in that scenario? I think nutrition is a really important key to that. When possible, I prefer using breast milk, especially the mother's own breast milk. And it's just got so many amazing things in it, specifically things we call HMOs, human milk oligosaccharides, but mother's milk also has immune benefits, good bacteria, and so many other things that we're still finding out. I mean, nobody actually knows everything that's still found in mother's milk. So to me, that's the number one thing. If and when able, start feeding mother's milk. If for whatever reason mother's milk is not available, you cannot get donor milk, then I think using some kind of nutrition that has HMOs in it, human milk oligosaccharides in it, is really important.
So if a baby, I think, Dr. Sangvi, if a baby is struggling with whether it's antibiotics or some sort of insult, I like the way that you said that, some sort of insult to the microbiome, what does that do like long term, 5 years, 10 years down the road? I know that you mentioned that some of the things that happen in those first 2 years affect them much greater than if they'd happened when they were an adult. Let's talk about what that is, what that looks
Yeah,
like.
and so the baby's microbiome is what we call less mature, less diverse. A normal
Okay.
adult microbiome should have a lot of diversity and a lot of maturity of the different kind of good bacterial species. What we find is if you've had an insult to the microbiome early in life, especially in what I call this vulnerable phase of 0 to maybe 2 to 5 years of life, we find that those babies, even when they're adults, so now the insult has gone away many years ago, but even when they're adults, their microbiome is still less diverse and still less mature than those babies who've not had these insults early on in life. And that has been linked to diseases like allergic diseases, autoimmune diseases, inflammatory bowel disease. We spoke about DGBIs like irritable bowel syndrome, but it's also now been linked to things like asthma, obesity, type 2 diabetes, cardiovascular disease. So we're still learning, but clearly we're learning the microbiome plays a way bigger role than we thought it ever would.
So is there a way to sort of usurp some of those things? Like, are there certain, either whether they're lifestyle changes, medical interventions, or there things that families can do that might either slow that, prevent that, or maybe just not even have it happen at all?
Yeah, and so again, the biggest thing I would say is a lot of things are out of our control in terms of insults to the microbiome. For example, a premature birth is really not in anybody's
Right.
control. An emergency C-section and needing emergency antibiotics. I think those are the three big, what I call hits to the microbiome. What families can do in situations where it is out of your control, and I think this is especially important for a mother that's breastfeeding, is taking care of yourself. Having a mother who's taken care of herself with good nutrition and managing her stress and mood, because listen, when your baby's going through things, all of us are going to be stressed out and have mood changes, but managing that in a healthy way helps create healthier breast milk, which is very good for the baby. So that's one. Number two, like I said, when able, you should use breast milk. It's really the best milk. If not able, then use a milk that has HMOs in it, that has pre and postbiotics in it. And then I also highly recommend, if you are ever, let's just say you've not had any of these situations and you are in a situation where your baby has a cold or a cough, I often find we as parents want quick fixes. And unfortunately, most infant colds and coughs are viral. And so antibiotics don't work for that. And so I always say, I think having a discussion with your physician and pediatrician about, are antibiotics truly needed in non-life threatening scenarios, is an important part of good microbiome stewardship.
Yeah, I do remember we had a lot of conversations with doctors specifically about that. We would say, well, we know that if we try vancomycin, for example, if we try vancomycin, what is that going to do? Like, does the cost outweigh the benefit? What are we looking at? And then should we pause it? And then should we come back? So there was a lot of discussion as to when to do it, how often to do it, how long to do it, because we were trying to ensure as healthy as a gut as possible.
Yeah, yeah. And it's a balance, Catherine, because antibiotics, you do want to use it for the duration of recommended treatment. Actually, stopping it early teaches the microbiome, and it's really the microbiome we're finding that starts encoding for genes for antibiotic resistance. So again, there's a balance. If you do it for the right indication and you do it for the right time period.
Yeah. No, it definitely at first I was like, "What's the big deal?" And then I realized as we were watching clinically, we were watching our son, I was like, "Oh, this is a big deal. This affects." Because as a kid, I was like, when you get sick, you take medicine and you move on, and it never dawned on me the deep effect, and certainly because he was born early, the deep effect that that was gonna have on him, not just in the NICU, but certainly years later. Okay, so you talked a little bit about nutrition. So we were talking about breast milk. What about when babies grow into toddlers and then they grow into preteens and young adults? How do you sort of maintain if your gut has been compromised? And then how do you maintain good, healthy habits in order to basically give it the best shot at being as healthy as possible as that baby grows up?
So I think again, at the risk of sounding repetitive, it comes back to nutrition. And so I really think, especially as the baby's weaning, having a healthy, well-balanced diet, especially with a good amount of fiber in it, is really important. And this might be too medical for you, but we know that certain fibers are really important for us because they don't actually get digested by human beings. So those fiber containing foods that we eat don't fully get digested by the enzymes we have. And that's where the good bacteria come in because they start digesting those fiber, I guess, containing foods. And then they form specific byproducts. And those specific byproducts, one example of them is something we call short chain fatty acids. Those are really important. Why? Because short chain fatty acids are the energy that your intestine uses to function. They also teach the intestine how to absorb fluid, electrolytes, nutrients, and they also help the intestine grow and proliferate. To me, though, a very important function also of short chain fatty acids is that it stimulates the body to release something very famous now called GLP-1. We've all heard about
Yeah,
GLP-1.
where have you heard that before? Yes, those are super important.
And so GLP-1 is a hormone that the intestine releases that essentially gives your brain the signal of, look, you're full and you don't need to be eating anymore. So having fiber in the diet is an important element for GLP-1 production through the microbiome. So I find that very early on, the kind of foods we expose our children to are really important. And so having a healthy, well-balanced diet with enough fiber is important. Having low, especially these artificial sugars, is really important early on in the diet because that's when your microbiome is teaching your body how to taste different foods and how that's producing what I call the reward behavior in the brain. So if you already have dysbiosis and on top of it, you're giving a lot of sugary foods, very early on, the circuit is being established in the baby that says, you need sugar to feel happy. And that eventually leads to these babies who need more and more and more sugar as they grow older. I also think as you grow older, I would say whatever, early teenhood, the kind of diet you eat, it still comes back to diet, is important. For example, are you going to eat a well balanced diet, maybe the Mediterranean diet, but just a well balanced diet based on what the old FDA or what the old USDA guidelines used to be? The Western diet is very high in artificial sugars, very high in, animal fats and, complex animal proteins. We're not entirely sure that that's good for your microbiome. And so I think that is something we want to be aware of. The second big thing is exercise. We know exercise releases endorphins and serotonin, which again helps your microbiome a whole lot. So, having some kind of regular exercise is important, not just to lose weight, but for your microbiome. And then I just say a healthy balance between washing your hands and being hygienic, but not going overboard and carrying that hand sanitizer everywhere and sanitizing everything is really important because your microbiome does need to have a little bit of exposure to, normal surrounding to understand what is safe and what's not.
Yeah, I would say that may be the biggest challenge for NICU parents is because we get so trained of everything needs to be clean. I was like hyper aware. And then I remember my husband at some point saying, "Well, he needs to live, Catherine. Like we have to expose him to some good things." So that exactly what you said, so that the microbiome knows what's good and what's not good.
Yeah.
So there are a lot, I think, of I don't want to call them complications, but things that make things tricky as those babies get older. It could be maybe Crohn's disease. It could be because maybe they had necrotizing enterocolitis. Maybe they have short gut syndrome. A lot of babies have reflux. So, what are some things that you look for to sort of help parents and also caregivers be like, okay, so these are some of the things that we should look out for. These are things that are preventable, and these are things that are not.
Yeah, I think really managing the diet, right? Because NICU babies end up usually having poor weight gain. And so
Right.
very early on, as parents, our focus becomes, I got to get this person to gain weight. And that's fine. And you don't want them to be obese. And so I think the appropriate amount of weight gain, and that doesn't shouldn't come at the cost of high sugary foods, because then you're really leading them down the path of obesity and all the complications that come with that. So I think that's one. I also think the other big important thing to be aware of or look out for is what you mentioned earlier, Kathryn, which is not being hyper protective in terms of just let them live, right? They've got to take their risks. They've got to be able to interact with the environment in the same way that somebody who did not have a NICU experience when they were born should have. And I think a lot of that comes with us as parents learning to manage ourselves. And I always say, my son graduated last year, and I always say our job as parents is the hardest job because our whole life we're training to make our kids independent. And yet when they become independent, it's the hardest thing to let go, right? So, but I think that starts very early on. So I think those will be a few easy things. I also say, look, just because they are, quote, out of the woods with the NICU doesn't mean you don't keep sort of a little bit of a check or an eye on how are you doing, how is any issues with, for example, constipation and or any issues with belly pain or something of that sort. I'm not saying you need to have this conversation every night at dinner because that is certainly going to be too much, but not just completely letting go, still being, trust your mom or dad instinct about, look, something feels off. And then the best next step is to talk with your physician or pediatrician and not go to Dr. Google or Dr. ChatGPT because everything is awful on those sites.
Yeah, no, when you read that, you're basically, we were self-diagnosing the other day, and I was like, I don't think this is healthy. I don't think we should keep going here. But I do think that I will say, as a NICU parent, there were moments, Dr. Songvi, where we were probably more aware of the gut just because of the trauma that he had early on. And so things like distended belly, or I remember, so I had four other children, and then I had this NICU baby, and like spitting up slash reflux was a big deal because I was like, I remember my other babies doing this, but then he was doing it more. And so I was trying to figure out what's normal, what's not normal. When should I call my pediatrician? When should I alert the neonatologist? Does his belly look distended? Like there was a lot of, I think, fear, but also I feel like I became a gastroenterologist over
Yeah,
those
yeah.
several years. So give us a glimpse into, let's sort of maybe focus a little bit on reflux. Let's give us a glimpse into healthy, normal microbiomes and what that does to reflux, and then when you should be like, that's concerning. We need to look into that.
Yeah. And so, talking about the early stuff, what I would just say first is if there's anything that worries you, you're the parent. You should really talk with your pediatrician at that point in time because that's what we pediatricians love. You'd come talk with us and we'll tell you this is something that to worry about versus I don't think you should worry about this. Okay. So I always tell my patients, I don't want you to be thinking twice about should I call my pediatrician or not. If in doubt, call us. We're always happy to hear from our patients. So let's talk about reflux. And I think there is what we call normal physiologic reflux that is important, and that's part of the natural process for every human baby. So let's talk about that first, and then I'll talk about, well, when does this sound like this is not the normal process anymore and it needs something different? So normally babies, and I would probably say 95 or more percent of babies have what we call physiologic reflux. The reason it happens is because a lot of the mechanisms you and I have to prevent reflux as adults are very immature in babies. Some of these include number one, we have a valve at the bottom of our swallowing tube that prevents food or acid coming from the stomach back into the esophagus. In babies, that valve doesn't develop until they're a little bit older. Number two, you and I are usually upright. Babies are usually sleeping. And then adults are usually having more solid foods. Babies are having more liquid foods. So, again, easier for things to come up. And then the other thing also is the diaphragm plays a really important role. It really pinches the bottom of your swallowing tube shut. And I really think the diaphragm in babies starts to get strong and develop its strength when the baby is able to pull to stand, which is about 6, 8 months or so. And so, in those first 6, 8 months, what's happened is you have all these immature reflux mechanisms. And yet, you're going to have a baby that, as compared to day one, by 4 months, is starting to crawl or be on their belly and sort of, spit up even more. So, the natural process is reflux is going to worsen before it gets better. It will peak somewhere between 3 to 6 months. Because remember, these mechanisms are immature, but your baby is a lot more active now before it starts getting better, close to 8 to 12 months, because now your diaphragm's getting more mature, your baby's eating more solid foods, and all these other mechanisms are becoming a lot more mature. I've often wondered, why is it nature is a really smart person, and I would say woman, because women are smart, but I think
I agree.
nature is really smart. So I've often wondered, why is it that nature made it that babies should have reflux? Why were they born with these immature things? Perhaps one of the best answers I've gotten is when you, again, going back to nutrition, going back to breast milk contains something in it called human milk oligosaccharides, which are a specific kind of carbohydrate or sugar that really has found to have multiple benefits, including immune, microbiome, etc. One of the benefits of HMOs is it acts as a decoy. What do I mean by that? Let's just say a bacteria wants to infect your respiratory tract. It won't directly usually bind to the respiratory tract. The bacteria binds to a sugar called a receptor on your respiratory tract, and it's the binding of the bacteria and the sugar that starts all the inflammation and infection. Well, like I said, HMOs are a sugar. And it turns out that almost all pathogens, bacteria, viruses, amoeba, HIV, has a much higher affinity for this HMO sugar than it does to the normal receptor on your cell. So, if the bacteria binds with the HMO, your body doesn't digest that HMO, it gets excreted out in the stool hole. So now think about it. When the baby refluxes, especially when they're fed breast milk, because that's what nature intended for them to feed, right? And there are studies that have shown that the entire upper respiratory tract, sometimes the ears as well, is all coated with these HMOs. And so that's nature's way of saying, look, if the baby gets an infection early on, that infection is going to bind to these HMOs and get excreted out and not actually infect the baby. So maybe we've all known this
Wow.
for years. Breastfed babies have less infections than those that are not breastfed. This may be one mechanism why. So I think that's normal reflux. And I always say if it's normal reflux, again, go to your pediatrician if you're worried. But normal reflux is good. It's a laundry problem. It's not a problem that needs medicines. Now, when do you know that this is not normal reflux? If the baby is spitting up and what I call projectile vomiting. So if you're holding the baby, it's going to go hit the wall. That's typically not normal. If the spit up contains not just milk or curdled milk, it doesn't matter whether it's liquid or curdled, but if it's now starting to have blood in it, or especially if it looks like there's green color liquid in it, then I'm really worried. If you find that the baby's spitting up so much that they're not able to gain weight, and that's by far the most common scenario when I worry about, listen, I think this needs treatment. So if they're throwing up more than they're able to keep in and they're not gaining weight, I think that's when something needs to be done. I would caution, I have a lot of parents that come to me saying, look, I gave them 2 ounces and they threw up 4 ounces. And I would be like, well, how do you know they threw up 4 ounces? And they say, well, because I measured a wet rag or something of that sort. And I always say, you can't, that's not very accurate because you always have digestive juices in the stomach. So I don't know how much came out. But I really look at the weight, and following the weight, especially early on, is a good indicator of are they able to keep their nutrition in. And then, of course, other things like belly distension, being overly fussy. Rarely we see things like having aspiration pneumonias, etc. I think those are times when I would worry about this is not normal physiologic reflux. I think this is something that needs a further evaluation and management. Now, the big controversy is hoarse voice and a red color larynx or pharynx, right? So the ENT physicians and the GI physicians, this is our point of contention where we disagree. I have had so many patients who say, my baby has a hoarse voice. I went to the ENT and they did a quick scope and said, oh, the throat is red, so this is reflux. Excellent studies. And I think you know Dr. Rachel Rosen from Boston Children's. She's done some excellent studies and shown that there's really no correlation between a red throat and reflux, which means you could have the worst reflux on earth and your throat could look normal, or your throat could look absolutely fiery red and it's got nothing to do with reflux. So I think really going to a pediatrician and, if needed, a pediatric gastroenterologist, and then getting right kind of studies done to assess, is this reflux? Is that reflux causing the symptoms? And how bad is the reflux? Will really help you go down the path of what's the right medicine for this.
Yeah, no, there is, I think, a lot of, we want to say like this one thing tells me this other thing. And really, it's a lot of different factors working together. There's a couple of things that you mentioned that I want to dive into a little bit deeper. So you mentioned if a baby is having reflux, but that color of that reflux is turning like, say, green in this example, what would that indicate to you, Dr. Songvi? Like, what when you see that, you're like, why is that alarming, and why is that a phone call or a visit to your pediatrician?
Yeah, and again, I don't want to say this and alarm parents, but usually
Sure.
green means there's bile that's coming out, and that means that something's not getting through the intestine. So is there a partial or complete blockage? Either physical blockage and or what we call functional blockage, which is the intestines not working normally to push food down. But that needs to be evaluated. And typically that's something I would say you need to evaluate in a little bit of an urgency if it's green color that's coming out. So that's the big worry. And of course, as you know, with babies, the big worry is if there's a blockage, are they going to lose blood supply? Is that going to lead to neck and surgery? So you want to evaluate that particular symptom in a little bit of a emergency.
So what about distended bellies? What does that tell you? I know I always feel like every time we go to the doctor, they're always, whether it's my NICU baby or not, they're always feeling their bellies and they're listening to their bellies. So I feel like you can shed some light on why that's important and what that tells you when it's not looking the way that it should.
Yeah, and so when I'm looking and listening to the belly, listening, I listen for what we call bowel sounds in all quadrants of the intestine. Like I said, I'm a motility physician, and so I'm always looking for, is the movement normal? And the bowel sounds and how often they're happening, what they sound like, give me a great insight into what's going on in the intestine. And this is, maybe I'm dating myself, but I'm one of those old time physicians who trained before, and I trained, in India. I did my med school in India. So we didn't have a lot of access to ultrasounds and x-rays, etc. So really, to me, that gives me a real good clue into what's going on. Belly, when I feel the belly, I'm feeling for a lot of things. Is there pain? But usually, do I feel lumps or bumps? I can feel poop. I've been doing this for so many years now. You can feel poop versus not. So that's some of the things I'm feeling for. And then, distension. Belly distension can happen literally for so many different reasons. It can range from gas, and that gas could be, look, the baby's swallowing a lot of gas, right? Or the gas could be you're constipated and you're not letting out that gas. And then everything in between. You may have lactose intolerance and you're still eating lactose, and that can cause some gassiness. So distension can be from gas, it can be from a blockage, it can be from constipation, it can be from lactose intolerance, it can be from dysbiosis causing what we call small bowel bacterial overgrowth. So just a variety of reasons that can cause abdominal distension. But I really think that's where your pediatrician and or pediatric GI is your friend and not chat gpt, because if you go to Google, they're going to give you this whole long list. And
Right.
Kathryn, you and me as moms are going to focus first on, oh my God, this is an obstruction, my baby's going to need surgery, and we're going to go down that
Right.
rabbit hole. But I think that's really where a pediatrician or pediatric GI will help you with, based on the clinical scenario, based on what I'm hearing in the belly, based on what I'm feeling in the belly, what you're telling me. Out of these 100 possibilities, I think these three or four are the more likely ones. And let's go down evaluating or managing these three or four.
Yeah, I definitely say of all the pediatric specialists that we had, the gastroenterologist was the one that I got to know the best. And that was not on our bingo card. I was like, I thought we were going to be getting to know the nephrologist or the cardiologist best, but it was really gastroenterology. And it's been something that we've dealt with. He's 17, almost 17 now, and we're still Still our best friend is the gastroenterologist. So if there's anybody that's a super fan of the gut, maybe you win over me, but I'm going to say that I'm maybe a close second. Um, are there some things, Dr. Songby, in a NICU that maybe like a NICU nurse may see and sometimes they just dismiss as like, oh, that's not that big of a deal. And you would say, actually, those are some things that you should look out for in your NICU babies that may not present just in a normal developing baby. Like, what are some things that people sort of write off sometimes? And you're like, actually, they should pay attention to that.
Yeah, I think the biggest thing is, and this sounds weird, but pooping in the first 24 to 48 hours of life. And, you want to have that black, sticky, tarry poop that we call meconium. Sometimes, and I'll tell you, NICU nurses are my favorite because they are
Agreed.
so well trained. I have I cannot, I can probably count on one hand how many times I feel a NICU nurse has missed something. And I think
Yeah.
there's more times where they've picked up something rather than missed it. So I'm going to start off with that. But sometimes what I found is, the NICU nurse will open the diaper and say, oh, yeah, I see meconium and it's all fine. You want to actually make sure that there is an actual active anal opening and there is, somebody's actually put their finger in that anal opening. Because one of the common things we find is some babies can be born with what's called imperforate anus. So there's actually no opening in the anus. Unfortunately, they do have unusual or not normal openings to different portions, the vagina, etc. So poop can come out from there. So if you're just going to open the diaper and say, oh, there's poop there, you may miss that. So that is one thing. And I think moms are really good. I don't know why somehow we're all obsessed with our baby's poop in our first few months of life, right? And so
Yeah.
I think moms are really good at that. If you feel, look, I think this is not normal. I think I see poop coming out from the baby's, I don't know, wrong part of the body, the vagina or something of that sort, let somebody know. It may end up being nothing, but that is something to know early on in life. The other thing that I often find, NICU nurses are so used to babies spitting up, but your baby, especially if you've held them for a few days. So something feels excessive. Look, this doesn't feel normal. I think this was more forceful than normal vomiting, or I think this was a different color. This was not the color of the formula or milk that went in. Let the physician know. And I think, again, it might end up being nothing most of the time, but it might be an easy way to pick something up. And then the last thing I say is fussiness. Look, all babies are fussy. And I think they go through this cycle of, every 10 days, just as you think you understood them,
Yep.
they flip. And then you're like, I have no idea why they're fussy, right? But if there is what you perceive as fussiness that's unusual, that's usually a sign that the baby's trying to tell you something. They're not happy about something. So I think it's good to escalate that to a physician's notice. I think those are some of the things, the obvious things, Kathryn, like, I don't know, throwing up green stuff, throwing up blood, abdominal distension. The NICU nurses are really good at that. So I
Yeah.
think those are some of the things I would pick up.
No, I think our NICU nurses picked up on that well before the gastroenterologist did, just because they'd spent so much time at the bedside and we were conferring and I was like, I'm seeing what you're seeing. And then the gastroenterologist came in and confirmed what we suspected, but it was nice to know that their eyes were on them. Are there things, because I know that you spend a lot of time talking about gut motility, your research, are there things that you're excited about that you're learning or that you're like, oh, we're on the cusp of something big? Like, what are the things that really get you excited about Preemie's guts and neonate's guts about what's coming next and what y'all can do to maybe intercede to make it either less of an issue or something that's going to change their life down the road?
Yeah, so one of my collaborators, and I'm working on this research with him, so I'm going to give a shout out to Dr. Eric Ortigosa from UT Southwestern. He's a neonatologist, and we've been working together, but it's really his brainchild. We're looking at, nobody knows what should be the normal speed of a newborn baby, much less what is the normal speed of the gut of a premature baby. And so, what Dr. Ortigosa is doing is trying to establish just that. What is the normal rate of movement of the premature gut versus a normal gut? And he's doing this without sticking tubes inside their intestines. It's just by something we call EGG, electrogastrography, and or measuring blood flow in different portions of the intestine before and after feeds. What we're actually finding with that is perhaps based on some very early results, we might be able to pick up necrotizing enterocolitis way before it actually becomes an issue, because we're seeing perhaps there are some changes in these motility patterns in these babies who eventually end up getting neck up to 48 hours before the neck actually got diagnosed. So I think I'm excited
Wow.
about that because, like you know, for NICU babies, necrotizing enterocolitis is the most devastating, one of the most devastating gut outcomes that happen. And picking it up early and sort of nipping it in the bud is an important part. So I'm excited about that. I'm also really excited, and you heard me talk about that, about this ingredient called HMOs or human milk oligosaccharides. I mean, any journal I look at now, there is at least one or two papers on this HMOs and what they do and why they're important, which again to me highlights the importance of breast milk and how amazing a thing it is. And so I'm excited about that. And I think both these things together um, will help us help these NICU babies a little bit more.
That is exciting. Okay, so let's go back to the neck things that you're looking at. So let's just say that the you call them EGGs, is that right?
Mhm.
Okay. So if you're doing those and you pick up on something, you're like, yeah, actually, I think we may have picked that up before it's starting to present in the baby. What would you do differently than I had you found it a couple of days later?
Well, you might start antibiotics a little bit sooner. You might stop feeding the gut a little bit sooner because in necrotizing enterocolitis, really the bottom line is the gut's not getting enough blood flow. So you don't want to put a lot of workload on a gut that's not getting enough blood flow. So you might be able to do that a little bit sooner. And you might monitor them a little bit more closely to say which ones are getting better versus not, so that you don't get to the point of abdominal distension, vomiting, etc. So I think that's really interesting for me. We're also finding some changes in the microbiome of these babies early on. So I think that's the other interesting thing is I don't know if that might help us pick up dysbiosis way earlier than we could have. I don't know. So it's exciting.
So I mean, I think the $1,000,000 question people are always asking is, while we don't necessarily know what causes neck, are there things that maybe some babies are more likely to get those? I do remember the neonatologist setting us down. Our baby was below 1,600 kilograms, and I remember them setting us down. I think I was post-op, and they mentioned something about it, and I was like, it's not going to apply to us. 9 days later, it did, but it feels like it's this. I hope no one gets this in the NICU, particularly among neonates. So it feels heavy, I think. And when you kind of reach a certain point, you're like, okay, maybe now we've reached the point that it's not going to happen to our baby. But what are some things that maybe make a baby more susceptible to contracting neck than maybe not?
The more premature you're born, the more likely you are to be at risk for neck. And again, that comes with the more premature you're born, the lower your birth weight is going to be. So, the lower your birth weight, the more likely you're going to have that. We also find sometimes, and I think that the data is sort of mixed on this, but feeding too much too quickly can also lead to neck. And our neonatologists are experts that we know exactly how many ml per kilogram we're going to give. And so I think sometimes enthusiastic parents push to feed a whole lot more, but there's a reason why you go at that specific rate because the intestine can only handle so much capacity. And then, of course, having other medical issues puts you at a higher risk for neck. So sometimes we see that our babies who have complex cardiac conditions, for example, may be at a little bit of a higher risk for necrotizing enterocolitis because again, the heart controls a lot of the blood flow to the whole body. So those are some I guess some scenarios. I do want to point out though that any baby can get neck. So it's not that, you're completely out of the woods, but these are more likely or have a higher risk, but any baby is at risk for neck.
Yeah. I love, yeah, the gut I think is fascinating and how we keep it healthy and what it allows all the other organs to do. I don't think I realized once a baby poops, like then all the other things that we worried about, certainly post-op, are very important. So I'm grateful that there's people that spend a lot of their time focusing on the health of the gut and what we can do to make it the most healthy it can be, certainly in babies that start out when it's less immature. So I know that you have spent a lot of time. I want to switch gears slightly. I know we have just a little bit of time left. You have spent a lot of time talking about equity in medicine, specifically opening doors for women in medicine. I know there's I've talked to some amazing specialists, some men, some women, some of color, and they are fascinating to me in the things that they're doing to make sure that the people that want to pursue medicine are able to do that and practice it well. So I would love to hear a little bit about what you do, particularly to promoting equity when it comes to women in medicine.
Yeah, and I think one of my biggest core values, Catherine, is fairness, right? And I feel like we were all created equal, and so we should have equal opportunities and equal quote reward for doing the same work. And so I do a lot of work on compensation equity. And unfortunately, even though we're in 2026, we still find that women physicians, dollar for dollar, make less money than male physicians. And there are multiple reasons why, but the bottom line is for the same work, usually men are making more than women doctors. And so I learned this really early on that you cannot make change without actually showing data. And so I lead our compensation committee at UT Southwestern. And every single year, we look at compensation for men versus women. And we see where the gap is. What is the gap? We look at it by rank. We look at it by, different reasons. But then we take it a step further because we then provide that data back to the leaders at the institution for them to say, hey, here's where we found the gap. And so I give a lot of kudos to our institution because they're very thoughtful about, well, why? Why is this the case? And let's look at this and let's try and sort of address it. And so I think that's number one. That's a big part of the work that I do, which really is you've got to be paid fairly. The second thing that I do is I mentor a lot of young women who want to become physicians, and I mentor them in different things. One is negotiation. We're not good negotiators as women, and in general, it's just a difference of a species, I think, right? Women are just smarter in so many other things, but maybe negotiation is not the jam for all women. And so I talk a lot about teaching them negotiating, understanding your worth, understanding your market value. And some of these are not easy data to get because a lot of this market value, what should a pediatric GI be paid in so and so place, are very difficult data to get. And so I really help mentor them with that. I also mentor a lot of women because we're unique in the sense when your parents and the child gets hurt, 90% of kids are first going to shout mom and when they get hurt. They don't shout dad when they get hurt. And so the reality is biologically, a lot of the upbringing of kids falls on women. And as you know, biologically, it's women who have to give birth and transform their body and breastfeed and all that stuff. How do you manage a career? That's when women are really starting
Right.
off in their career. How do you manage a career at that time? I apologize for that, but how do you manage a career at that time while you're usually just setting off in your career, right? When you're having young babies. So, how do you handle that work life balance? And how do you fully appreciate and enjoy your role as a mother, along with being a young physician, is something that I really mentor them on. And then the last thing I mentor a lot of women on is leadership. I think leadership, there's a huge inequity in medicine. If you look around, you'll find that the phenotype, which is how the leaders look, is very, very one type and one color. And so I really mentor a lot of women into knowing their worth, applying for leadership positions, even if they're not 100% ready. A lot of research has been done that actually shows that women have you want to be 90% ready before I'm going to apply for this job, and men are like, I know 5% of this, I can apply and wing it. So that mindset change is something.
So fascinating. So what's the ratio, particularly in neurogastroenterology, Dr. Sangvi, of females to males?
I don't know that data. When I look around me, though, I feel it's fairly well distributed. However, I do see that there are a lot more male leaders in neurogastroenterology than women. I want to give a shout out to Dr. Rachel Rosen. She is on the American Neurogastroenterology and Motility Society leadership. She is a huge champion for women in neurogastroenterology. She's my mentor, and I'm in the Rachel Rosen fan club. If you didn't know that already, you didn't guess that. So I think she is an inspiration. And I think having leaders like that has helped a lot of other young women in neurogastroenterology get pulled up, so to say, in the ranks.
Yeah. Well, as the last question to kind of circle it back to the microbiome, what, Dr. Sanghavi, if you could maybe leave people with one thing that you hope that they walk away with knowing more about the preemie microbiome, what do you want them to know? What do you want them to walk away with?
Yeah, I think I want them to walk away with the microbiome is the most important, clearly biased, and the most
You're not biased at all. It's okay.
is the most important, the most magical part of a growing baby. And most importantly, it's the part that we can actually influence and make a difference on early in life. And so being aware of that, because it controls so many things like we spoke about, being aware of that, respecting the microbiome, both with respect to antibiotics, hygiene, but also nutrition, really is the key not just to a healthy childhood, but is then the key to a healthy adulthood and beyond. And I think understanding that really changes your perspective of things.
Co-sign that, and I'm not even a medical doctor, but I can tell you that it's a huge part of development, and like you said, I like the way you said that it's magical. I love it when doctors actually own and love whatever organ it is that they're a specialist in, because it tells me that you're in the right place, because you believe that your organ, your part of the body is the most important. But in this case, I'm going to agree with you. I think it is. So we agree. Well, Dr. Zongvi, thank you for the gift of your wisdom, but also of giving people an idea of what things come about when we can intervene, and then when we can't intervene, how we can make the best possible outcomes. It's fascinating. So thank you.